Hi everyone, welcome to 1PM. Just a reminder that you're listening to the summary version of this discussion.
In terms of the approach and the sort of archetypal presentation of a patient with diabetic retinopathy, the things that you're looking out for in the exam or in real life are a middle-aged, vasculopathic patient with poorly controlled diabetes. You're looking for gradual, progressive bilateral decline in vision. The most important exam you're going to need to do is fundoscopy, or having a look at the back of the eye to look for those structural changes that are consistent with diabetic retinopathy, that being the microaneurysms, dot and blot hemorrhages, hard exudates, cotton wool spots, venous beading, and the intraretinal microvascular abnormalities. In this scenario, what investigations might you consider ordering?
So we can think of bedside bloods imaging.
Yep.
In terms of bedside, there's no real bedside investigations unless you count like a slit lamp. You want to get basically like your metabolic syndrome bloods.
Yep.
So HbA1c, lipids, UECs, you can get a urine ACR, especially because in diabetes patients will often get albuminuria, and like LFTs for, a metabolic associated fatty liver disease.
So I guess all that's left for our topic, or our discussion of this topic, diabetic retinopathy, is to touch on management. The management of diabetic retinopathy is in part governed by the type of retinopathy the patient has, right?
Yeah, in non-proliferative diabetic retinopathy, there's no real specific management from the eye perspective, but generally you want to do all of your good diabetes management. So in terms of non-pharmacological things, that's optimizing their diet, their exercise, smoking cessation. That's real important. If in an OSCE it's mentioned that they're a smoker, you have to flag that as an issue. Weight loss, you want to manage their other comorbidities, so lipids, blood pressure, and achieve good glycemic control.
Yeah.
You need to send them for ongoing ophthalmic review. So you've now diagnosed, we know they have this condition, they need to be seeing an ophthalmologist.
Yeah.
If they don't have retinopathy and they just have diabetes, the general screening recommendations is 2 yearly by an optometrist or an ophthalmologist.
Yeah.
If they have diabetes, but they're particularly high risk for any of the risk factors we mentioned, or they're indigenous, they require annual screening.
For patients with neovascularization, because there is that neovascularization, there are some specific treatments that ophthalmologists can use to target that. So Joe, do you know any treatments specifically?
I do. I know two.
You know two. Talk us through them.
Well, I know first line is laser photocoagulation.
Yep.
And our anti-VEGF treatments as well.
Okay. The most important take-home messages from today would be to understand that diabetic retinopathy represents microvascular and organ damage to the eye that occurs because of diabetes. It's a clinical diagnosis which you can make when you have a patient that has diabetes, as well as the characteristic fundoscopy changes that we've really harped on about for the past sort of half an hour. The mainstay of management of diabetic retinopathy is improved glycemic control. However, for patients with proliferative disease, there are specific management options, including retinal laser, as well as anti-VEGF intravitreal injections. And then I think for DMO, the most important thing as a medical student is just to know that it's diffuse capillary and microaneurysm leakage in the macula, which commonly produces noticeable visual symptoms, and it can occur at any point. It doesn't have to be at end stages.
Cool.